Good morning. This is Karen again, and I'm here to cover this week's objectives. First, I want to apologize for getting this to you late. I've been in Honduras trying to set up a respiratory school and teach at the hospital as well as doing some clinical help in ICU and in ICU. And I had trouble getting home in time to get this mail to you. So I'm starting from scratch basically on my recordings because some of my recordings were pretty dark due to lighting and internet. So sorry again. Today we're going to cover polysomnography and portable monitoring. So thank you for your patience to start off with. As stated in your syllabus, we're going to go over the 7 objectives listed for polysomnography and portable monitoring. And they include explain the various indications for performing polysomnography, explain what portable monitoring is and the classification of monitoring devices, outline the differences in AHI by portable monitoring versus polysomnography monitoring. Also included is to identify the concerns and accuracy of portable monitors, explain the type of portable monitoring devices and explains its indications, outline the practical considerations in portable monitoring, and choose between portable monitoring and PSG for a given patient. First off, I want to ask the questions, why do a polysomnography? First of all, it identifies if or when your sleep patterns are disrupted and why. And normally you go through normal cycles at night in which you cycle between non-REM and REM sleep in about 90 minutes. And sleep disorders can disturb this process. So we're going to talk about ways to monitor the patient to observe these particular things with the sleep cycle and breathing patterns. We talked a little bit about polysomnography in previous weeks, but just to redefine it, it is a comprehensive test used to diagnose sleep disorders. It records brain waves, oxygen levels, blood in the blood, heart rate, and breathing and eye movement during sleep. Typically performed at night and can be done during the day for shift workers who sleep during the day. It's used to initiate or adjust treatment plan if already diagnosed, and sometimes it can be done at home in primarily diagnosing OSA. Portable testing is a reasonable alternative to inpatients with high pretest probability of moderate to severe obstructive sleep apnea. Portable testing should not be routinely ordered in those patients with coexisting sleep disorders, class 3 obesity, and severe cardiopulmonary disorders. A negative portable test should prompt an in-laboratory polysomnography. Portable testing is cost-effective in selected group of patients, mainly from the insurance payer perspective, and cost-effectiveness can be enhanced when it is in collaboration with a sleep center to ensure that appropriate follow-up and adherence to treatment. Further research is needed to determine if portable testing is effective in diagnosing OSA. Your doctor may recommend polysomnography if he or she suspects you have sleep apnea or another sleep-related breathing disorder. Breathing repeatedly stops and starts during sleep, periodic limb movements disorder, which involve involuntary flex and extension of your legs while asleep, sometimes associated with restless leg syndrome, narcolepsy, overwhelming daytime drowsiness, and sudden attacks of sleep in this condition, REM sleep behavior disorders, acting out dreams in sleep, and unusual behaviors during sleep, such as walking, moving around, eating, and a lot of arithmetic movements. We're going to move to the next objective, which is explain what is portable monitoring and the classification of monitoring devices. In 2007, AAS guidelines for portable monitoring task force developed clinical guidelines for use of portable monitoring in the diagnosis and management of OSA. It required 6 hours overnight recording minimum for the portable study, and the portable testing may be used as an alternative to PSG for the diagnosis of patients with OSA. It's less expensive and quicker to deploy compared to the in-lab PSG. High pretest probability of moderate to severe OSA, and for whom in-laboratory PSG is not possible due to immobility or critical illness. Portable monitoring is not appropriate for diagnosis of OSA in patients with significant comorbid medical conditions such as advanced cardiopulmonary disease that may degrade its accuracy, with evaluation showing suspicion of having comorbid sleep disorders and with screenings of belonging to an asymptomatic populations. This task force that developed the guidelines for portable testing stated that at a minimum, portable testing must record airflow, respiratory effort, and pulse oximetry. Application, education, testing, scoring, and interpretation must be performed under a AASM accredited comprehensive sleep program. A negative or technically inadequate portable testing with high pretest probability of moderate to severe OSA should prompt an in-laboratory PSG. We are still in the objective to explain what is portable monitoring and the classification of modern devices. I want to go back to the level 1 standard PSG, which is required for this testing. When you look at the parameters for a standard PSG, in-lab PSG, there must be a minimum of 7 different ways to measure, including EEG, which is electroencephalogram, EOG, eye movement, chin muscle, EKG or ECG, airflow, respiratory effort, and oximetry. The body position must be documented or objectively measured. Leg movement can be monitored by EMG or a motion sensor, but this is considered optional. Personnel attendant is constant and available during the PSG, and intervention possible should be included, like CPAP. Now I'm going to explain the different levels for comprehensive portable PSG, and this is a level 2. According to the parameters, you should have a minimum of 7: EEG, EOG, eye movement, chin movement, EKG or heart rate, airflow, respiratory effort, and oximetry. Body position can be objectively measured. Leg movement or motion sensor, EMG, is optional. Personal attendance, none is required, and interventions possible, no, they're not available. I'm going to outline the next level, which is level 3, the modified portable apnea testing. The parameters include a minimum of 4: ventilation, which can be respiratory movement and airflow, heart rate or EKG, and oximetry. Body position can be objectively measured. Leg movement may be recorded. Personal attendance is none, and intervention possible, there's none available. These are considered at home testing. The last one I want to talk about is continuous single or dual parameter recording. The parameters include minimum of 1, typically oximetry or airflow. Body position is not measured. Leg movement is not recorded. Personal attendance, none, and interventions possible, none. Again, we're under the same objective of portable monitoring and a classification of monitoring devices. There's really 2 types of studies that can potentially detect obstructive sleep apnea: overnight study in the lab or at the hospital, and a home sleep apnea test. The home sleep apnea test does not measure brain waves during sleep. It does measure other factors that can help medical professionals determine if a person has OSA, but offers several advantages over the in-lab polysomnography. So what is an at-home sleep test? It's done at a home environment, conducted outside of the hospital or sleep lab. This type of testing can accurately diagnose obstructive sleep apnea in some, but not all people. It costs less than the lab and is more convenient than in-lab testing. Generally, you pick up special equipment and you follow the instructions to apply, then return it to sleep specialists who will analyze the data to see if you meet the diagnosis of OSA. Equipment that may be included depending upon the type of home sleep testing may be a breathing sensor that analyzes breathing patterns or by tracking air pressure when inhaling and exhaling. The pulse oximeter placed over a fingertip to measure how much oxygen is in the blood. Microphone to estimate snoring with a sound sensor attached to the neck, and data collection device either via wires or flexible tubes, which may feature buttons you are instructed to push when you want data collection to begin, as well as lights indication when the device is powered on. How does a home sleep study work? Well, first of all, you need to talk to your doctor if you're having symptoms and not getting adequate sleep at night. It may be something that your sleep bed partner observes, and they can help you with that when you go into the doctor. So talk to the doctor. Then once the doctor thinks you need a sleep test, you'll consult with a sleep specialist, which is a physician that specializes in sleep medicine. Obtain a home sleep apnea test equipment, typically given out by the lab, giving the test, or maybe the doctor's office. Carry out the test at home, then return the equipment and learn about the results. Treatment in the future may include the addition of CPAP material, and you may have to repeat the sleep test at home with the CPAP on to see how effective it is. Next, let's talk a little bit about sleep trackers. What are sleep trackers and do they work? What do the sleep trackers monitor? Activity trackers are all the rage within the millions of wrists, monitoring everything from heart rate, oxygen consumption, and a number of steps and more each day. Sleep trackers monitor the sleep duration, sleep quality, and sleep phases. May include all of those or may just include one. There are varieties of sleep tracker types, and I'm going to talk a little bit about each one, which is a wearable. A wearable is you wear the device on your wrist or finger while sleeping, typically to collect data about your movement and heart rate. Some track your breathing. You can also track your food and track daytime physical activity. The bedside devices is placed at the bedside, and they collect data about your body movement, breathing, and room environment. Bed sensors are sensors that you place under your sheets or mattress, collect data about body movement and heart rate, and track room environment. Some do's and don'ts of using a sleep tracker. Use the sleep tracker for total sleep time and sleep habit goals. Don't use the sleep tracker for determining quality of sleep. You do use the data collected to start a conversation with your doctor. And don't lose sleep over your sleep tracker by fidgeting with the controls and worrying about it as it's applied during the night. Portable monitoring devices rely on interpreting movements, so it can only be used in the context of certain sleep disorders. Insomnia, which include insomnia, circadian rhythm sleep disorders, sleep apnea, insufficient sleep syndrome, or multiple sleep latency test. Frequently asked questions about the portable monitoring systems or the at-home sleep studies. One includes, how much do home sleep studies cost? Across the United States, the cost ranges from $150 to $500, and often the health insurance covers some or all of the cost. You may have to pay the deductible if you haven't met it. How accurate are home sleep tests? Type 3 home sleep apnea tests are highly accurate in detecting obstructive sleep apnea in the moderate to the severe form. This test becomes less accurate as people with certain other health or sleep disorders. How many times can I take a sleep at home test? Generally, people take a home apnea test once. If the test is not enough to have diagnosed obstructive sleep apnea, they may be instructed to go to the lab for an overnight sleep test. What sleep disorders can be tested at home? These are used to detect sleep disordered breathing problems like obstructive sleep apnea. Some do not actually measure the brain waves of sleep, and they are not capable of diagnosing other sleep disorders. Will insurance pay for sleep studies? Yes. Many health insurance cover the plan. The amount of coverage depends upon your insurance company and other medical provider. Medicare Part B, for example, requires people to pay a portion of the study cost as well as the deductible. Check with your insurance company prior to testing to see what's covered. Who should not take a home sleep study? A patient with congestive heart failure, severe or chronic pulmonary disease, neurological or neuromuscular disorders, other sleep disorders like narcolepsy, parasomnias, and periodic limb movement disorder also may be less accurate in detecting mild sleep apnea. The downside would include the potential for misdiagnosis as not having OSA when they do, and having a milder version than they actually do. The next couple of slides, I'm going to describe the different types of portable monitoring systems. The S1 is requires that they have 3 EEG channels, eye movement and chin EMG, EKG leads, finger or ear oximetry, video or visual measurement, RIP belts, and nasal pressure and thermal device. Portable monitoring, S2, includes eye or chin EMG, peripheral artery tone, finger oximetry without sampling, non-visual position state measurement, and 1 RIP belt, and nasal pressure. S3 is a sleep surrogate using actigraphy, 1 lead for EKG, oximetry alternative site, derived effort, and thermal device. S4 includes other sleep measures, derived pulse from oximetry, other oximetry, or other effort measurements, and or ECT entitled. Okay, we've gotten through the first 2 objectives for this week, so hang in there. We have 5 more to go. The third one that we're going to cover is outline the differences in AHI by portable monitoring versus polysomnography. Let's define AHI first. Apnea-hypopnea index. This apnea-hypopnea index is a diagnostic tool for determining presence and severity of obstructive sleep apnea. Apnea is defined as a collapse of airways during sleep for at least 10 seconds. Hypopnea occurs when the airway partially collapses, resulting in shallow breathing decreased by more than 30% for at least 10 seconds. Apnea and hypopic events disrupt sleep and lead to lower blood oxygen levels. Different than central apnea, hypoxic index, which is used for central sleep apnea. The AHI is measured on a numeric scale. 3 categories which correspond to different levels of OSA severity in adults include mild, moderate, and severe. An AHI of at least 5 events per hour but fewer than 15. Moderate is an AHI of at least 15 events per hour but fewer than 30. And a severe is an AHI of at least 30 events per hour. The 3 categories in children is different in that mild is greater than or equal to 1 or less than or equal to 5. Moderate is greater than 5 or less than or equal to 10 events per hour, and severe is 10 events greater than 10 events per hour. The difference between AHI between home sleep testing and in-lab sleep testing has to do with the total recording time. Home sleep tests calculate the AHI on the total recording time as opposed to in the polysomnogram to more than a precise tool of total sleep time measured in the polysomnogram from sleep onset. As a result, home sleep tests often underestimate AHI by 15%. How is AHI measured? Well, it's the average number of apneas and hypopneas experienced each hour during sleep. Divide the number of apneic and hypopneic events by the total number of hours you were asleep. An event must last at least 10 seconds or longer, and while the AHI is the primary measurement of diagnosing OSI, the oxygen desaturation index measures how many times per hour on average your blood level falls below normal or 10 seconds or longer. Okay, we're moving on to the next objective, which is identify the concerns with accuracy of portable monitoring. And that is number 4 of the 7 that we're covering. So I just want to review a typical sleep time and sleep cycle and what it looks like. So stage 1 is lasting only a few minutes. On the first sleep is light, and the first sleep is very light. Stage 2 is during this stage, which is also fairly light, but the brain waves begin to slow. In stages 3 and 4, during this stage, you move into a deeper sleep, and it's harder to wake up from it. This is the time your body grows and repairs itself and boosts immune function. Rapid eye movement is during this stage in sleep cycle, your brain becomes more active. and dreams occur. Your brain is processing information, storing long-term memories. This cycle repeats itself from every 90 to 110 minutes. As the sleep progresses, REM cycle increases in length. Some of the concerns with accuracy include the reduced flow monitoring time. The respiratory events are missed and resulting in underscoring of AHI, especially in children. In lab testing, it gathers more data. In lab testing, it's more likely to pick up sleep apnea and other symptoms. If you have any reason to believe you need more comprehensive tests, then it might be worthwhile to skip the home test and go directly to the sleep lab. Home sleep tests are only used to diagnose sleep-disordered breathing issues like sleep apnea. But in contrast, the in-lab sleep studies can help diagnose other sleep disorders like narcolepsy and periodic limb movement disorders. As explained earlier, there are 3 types of portable monitoring devices, and they classify under the S1 through S4. And they were wearables, bed sensors, and mattress sensors. So actigraphy is a type of wearable sleep test that tracks your movements to analyze when you are asleep and when you're awake. This device can help doctors diagnose certain sleep disorders and monitor treatments. Based on your movements, actigraphy attempts to calculate sleep parameters such as what time you fall asleep, what time you wake up, how long you take to fall asleep, and how long you sleep in total, how much time you spend awake during the night after falling asleep, and progress of people who have been already diagnosed with this disorder. Many portable testing devices are not the same with the continued technology advances. Clinicians needed guidance to help decide with out-of-sleep center testing and are they appropriate for OSA. In 2011, new categorization scheme was developed, allowing easier guide to which devices should be used. And we covered those in previous slides. The Scooper categorizations included sleep, cardiac, oximetry, position, and respiratory movement. Vast number of trial validating the outpatient use was performed, and evidence that portable testing is a reasonable substitute for in-lab PSG. Was used on adults with suspected OSA confirmed, and the limitations that they are not outcomes as in the lab sleep testing. Excluded were patients with comorbidities. There was also a traditional model which was that there was a clinical sleep evaluation with in-lab testing and in-lab CPAP titration, where home testing used clinical evaluation, home portable monitor, and home APAP titration. Okay, we're at the last objective, which is choose between portable monitoring and PSG for a given patient scenario. So I'm going to give you a couple cases. Suspicion of OSA includes low pretest probability, suspicion of comorbid sleep disorder, severe cardiac, pulmonary, or neuromuscular disease, and class 3 obesity. With this type of patient, a full lab sleep test would be more practical because we can monitor more things, and we can also look at cardiac and any other disorders that may be going on. So for this example, we would use in-lab testing. Okay, this patient has suspicion of OSA and has a high pretest probability of moderate to severe OSA. They're immobile or they have a critical illness. So this type of patient would recommend to have an at-home testing, mostly because of the immobility and critical illness, and they have a high probability of moderate to severe OSA. Okay, this patient, again, the doctor is suspicious of an OSA. They have a high probability of moderate to severe OSA. They're diagnosed with CHF and narcolepsy symptoms. So this person would probably qualify and be more accurately tested in the lab because of the comorbidities of CHF and narcolepsy. Okay, we've come to the end of our objectives and covered them through this lecture. I hope that this is helpful for you in understanding the polysomnography and portable monitoring. Again, I apologize for this late submission of this lecture due to my travels to Honduras in teaching and setting up a sleep respiratory care program there. If you have any questions, feel free to email me and I'll try to answer them. I will be sending out the PDF to your instructor so you have these for your notes, and please finish the quiz. Again, thank you for your patience in receiving this, and I hope next week we can talk live. Have a good week.